Hi everyone, welcome to chapter 15, part D. We're discussing the special senses. We have discussed the olfaction, the tasting, as well as part of the hearing. So here in this chapter, we'll finish up the hearing and discuss some of the clinical aspects of it. So under the hearing, we have to discuss the sound detection. So hearing is the reception of an air sound wave which converts to a fluid wave which ultimately stimulates the mechanosensitive cochlear hair cells and leads to send impulses to the brain for interpretation. So before that, we have to learn some of the properties of the sound. So sound is a pressure disturbance, alternating areas of high and low pressure, which is produced by a vibrating object and propagated by molecules of the media, which is the air. Sound waves are created when an object moves. So when an object moves, the air molecules that are displaced by object movement are pushed forward into adjacent area, adding to air molecules already there. So it creates an area of high pressure due to the compression of molecules together. As the object returns to the original position, the area it leaves now has fewer air molecules, so it creates a low pressure due to presence of fewer air molecules, which we call as the rarefaction. So sound waves are alternative areas of compression and rarefactions. So objects vibrating cause waves to move outward in all directions as air all around is compressed and rarefied. The kinetic energy of the object is transferred to air molecules, which then transfer it to the other air molecules. And the wave energy going to decline with time and distance. The wave can be illustrated as an S-shaped curve or a sine wave, which is the compressions shown as crest and the rarefactions as troughs. So here it's been shown, if you look at with the wave curve, the S curve, that the compression areas as the crest and the low pressure areas, the rarefaction areas as the troughs. The sound can be described by two physical properties according to the frequency and the amplitude. Frequency is the number of waves that pass given point in a given time. The pure tone has repeating crests and troughs. The wavelength is the distance between the two consecutive crests. Shorter the wavelength, it's the higher the frequency of the sound. Wavelength is consistent for a particular sound. The frequency range of human hearing is 20 to 20,000 Hertz, but most sensitive between 1500 to 4000 Hertz. The pitch is the perception of different frequencies. Higher the frequency, higher the pitch. The quality of the characteristics of sounds is most sounds are a mixture of different frequencies. The tone is said as the one frequency. The sound quality provides richness and complexity of sounds. So here it shows the high frequency sounds, which is the shorter wavelength, which is been shown in red. So here, if you take 1S, you would see 3 waves, 3 crests in one low frequency wave. The low frequency is the long wavelength, which is the low pitch. The amplitude is the height of the crest. Amplitude perceived as loudness, subjective interpretation of sound intensity. It's been measured in decibels, and the normal range is 0 to 120 decibels. Normal conversation is around 50 decibels, and threshold of pain is 120 decibels. Severe hearing loss can occur with prolonged exposure above 90 decibels, and amplified rock music is around 120 decibels or more. So that's kind of have to remember when you go to musicals and so on. The pathway of sounds is important to understand the transmission of sound to internal waves. So the tympanic membrane, its sound waves enters the external acoustic meatus and strike the tympanic membrane, causing it to vibrate. The higher the intensity, the more the vibration occurs. Then the auditory ossicles transfer this vibration to the oval window. And tympanic membrane is about 20 times larger than the oval window, so the vibration is transferred to oval window is amplified around like 20 times. The stapes rocks back and forth on the oval window with each vibration, which causes the wave movements in the perilymph, and the wave ends at the round window, which causes it to bulge outward into the middle ear cavity. In the helicotrema pathway, the waves with frequencies below threshold of hearing travel through helicotrema and scale tympani to the round window. And from the basilar membrane pathway, the sound is hearing range go through cochlear duct, vibrating basilar membrane at specific location according to the frequency of the sound. So in this figure, it shows the sound waves vibrate to the tympanic membrane in here, and then the auditory ossicles vibrate, and the pressure is going to amplify, and the pressure waves then created by the stapes pushing the oval window move through the fluid in the scala vestibule, and then the sound waves frequency below hearing travel to the helicotrema pathway over here, and the sound waves in hearing range go through the cochlear duct, vibrating the basilar lamina and deflecting hairs on the inner cells. The resonance of the basilar membrane, the resonance means is the movement of different areas of the basilar membrane in response to particular frequency. The basilar membrane changes along its length, and it could be due to two ways, like fibers near the oval window are short and stiff, so the resonant with high frequency waves, it's resonate with high frequency waves. The fibers near the cochlear apex are long and floppier, so those resonate with low frequency waves. So the basilar membrane mechanically processes the sound even before signals reach the receptors. And the movement of the basilar membrane deflects the hairs of the inner hair cells. And the cochlear hair cells have microvilli, which contains many stereocilia that bend at their base. And also the longest hair cells are connected to shortest hair cells via called tipplings. The tipplings, when they're pulled on, they open up ion channels they're connected to. So the stereocilia, they project into potassium-rich endolymph with longest hairs enmeshed in the gel-like tectorial membrane, and the bending of the stereocilia toward the tallest ones pulls on the tipplings, and they cause the potassium and calcium ion channels in the shorter stereocilia to open. And once these ion channels open, the potassium and calcium ion flow into the cell, causing receptor potential that can lead to release of neurotransmitter, the glutamate, and that will trigger an action potential in the afferent neurons of the cochlear nerve. Bending of stereocilia toward shorter ones cause tipplings to relax, and then the ion channels closes, leading to the repolarization process, and sometimes it could lead to the hyperpolarization as well. So here you would see the tipplings, and they are connected, and in here the basilar membrane at rest. So a few channels are open and cells are slightly depolarized. The hair cells in this figure is bending towards the tallest stereocilia in here. And then the tipplings get tightened, opening mechanical gated ion channels, and the more cations enter the cells and they depolarize. The neurotransmitter released, and then the action potential is generated at the cochlear nerve. Then at the resting state, the tallest the stereocilia is moved away from the tallest stereocilia. The tipplings loosen, closing the channels, and then the nerves is going to repolarize and sometimes even hyperpolarize. The action potential stops. The role of the outer hair cells, the nerve fibers they coiled around the hair cells of the outer row are the efferent neurons, which convey the message from the brain to the ear. And the outer hair cells, they can contract and stretch, which changes the stiffness of the basilar membrane. And this ability serves two functions, which is increase the fine-tuning responsiveness of the inner hair cells by amplifying motion of the basilar membrane, and they can protect the inner hair cells from loud noises by decreasing the motion of the basilar membrane as well. The other important topic that we need to know about hearing is the auditory pathway. The neural impulses from the cochlear bipolar cells, they reach the auditory cortex via this following pathway. That is, first the spiral ganglion, then the cochlear nuclei, the superior olivary nucleus, and then the lateral lemniscus, the inferior colliculus, the medial geniculate nucleus, and then the primary auditory cortex. Some fibers can cross over, some do not. So both auditory cortices receive input from both ears. So here it shows again the pathways that we have discussed in the previous slide. The bipolar neuron, and at the medullary level, the superior olivary nucleus in the pons, and then the midbrain, it travels through and to the inferior colliculus, to the primary auditory, towards the end, medial geniculate nucleus of the thalamus, and then towards the end, the primary auditory cortex in the temporal lobe. The perception is also important because during the auditory processing, there are several important topics that we need to know. So first, the perception of the pitch. That is, the impulses from hair cells in the different positions along the basilar membrane are interpreted by brain as specific pitches. And also, the detection of loudness is determined by the brain as an increase in the number of action potentials that result when hair cells experience large deflections. And the localization of the sound, it depends on the relative intensity and relative timing of sound waves reaching the both ears. And if timing is increased on one side, brain interprets as the sound is coming from that side. We know now, like, one of the other function of the ear would be the equilibrium, play a role in the equilibrium other than the hearing. So let's look at how does the ear do so. The equilibrium is a response to various movements of the head that rely on input from inner ear, eyes, and the stretch receptors of the body. The vestibular apparatus is involved in this process. It does have the equilibrium receptors in the semicircular canals and the vestibule. The vestibule receptors monitor the static equilibrium. The semicircular canal receptors monitor the dynamic equilibrium. The macule is the sensory receptor organs that monitor the static equilibrium. It's one organ located in each saccule wall and one in each utricle wall. It monitors the position of the head in space and plays a role in control of the posture. It responds to the linear acceleration forces, but not for the rotation movements. The anatomy of the macula, it Each macula has a flat epithelium patch containing hair cells with supporting cells. So the hair cells have stereocilia and special true stereocilium called kinocilium. They're located next to the tallest stereocilia. These stereocilia are embedded in the otolith membrane, which is a jelly-like mass studded with otoliths, that is tiny calcium carbonate stones. So otoliths, what they do is they increase the membrane's weight and increase its inertia, that is the resistance to change in the motion. The utricle macula horizontal with vertical hairs, and they respond to change along the horizontal plane and the movements such as the tilting of head. And of course, the forward and the backward movements, they stimulate the utricle. The saccule of the macula are vertical with horizontal hairs, so they respond to change along the vertical plane, which is the up-down movement stimulate the saccule, such as when you're traveling in an elevator, the acceleration of the elevator as such. The hair cells, they synapse with the fibers of the vestibular nerves, and the vestibular nerve cell bodies, they are located in the superior and the inferior vestibular ganglia. And that is part of the vestibular cochlear cranial nerve. So here it shows the structure and the function of the macula. This is the macula saccule and the macula utricle over here, and it's been shown the higher image of the macula utricle. Here you see the hair cells, the supporting cells adjacent to the hair cells, the vestibular nerve originating at the hair cells, the otolith membrane, which is the gel-like structure, the otoliths, the calcium carbonate, bony calcium carbonate molecules, and then the kinocilium, which is the tallest, associated with the tallest stereocilia. So activating receptors of the macula, the hair cells release neurotransmitters continuously, and then acceleration or deceleration causes a change in the amount of neurotransmitters released. And that leads to change in the action potential frequency to the brain. The density of the otolith membrane causes it to lag behind movement of hair cells when the head change positions. And base of the stereocilia, they moves at the same rate as the head, but the tips embedded in the otolith, they're pulled by lagging membrane, causing hair to bend, and the ion channels open and depolarization occurs. Due to the bending of the hairs in the direction of the kinocilia, what will happen is it depolarizes the hair cells, increases the amount of neurotransmitter release, and more impulses then travel up to the brain. Bending away from the kinocilia, that will lead to hyperpolarize the receptors and the less neurotransmitters released, and that will reduce the rate of the impulse generation, and therefore, or bending towards the kinocilia will inform the changing of the position of the head. Which shows again the head upright position, steady stream of action potential. In the vestibular nerve, you would see head tilted toward, then the hair bends toward the kinocilia. This depolarizes, the nerve fibers get excited, the action potential is generated, and head tilted backwards bends away from the kinocilia, and then that will lead to the hyperpolarization and reducing the action potential in the vestibular nerve. With related to the equilibrium, the crista ampullaris is important as well. So the receptors for rotational acceleration is the crista ampullaris, or we call it in short form as the crista. So in the ampulla of each, it's a small elevation in the ampulla of each semicircular canal, and the crista is excited by acceleration and deceleration of the head. The major stimuli are the rotational movements such as twirling of the body and the semicircular canals located in all three planes of the space. So crista can pick up on all rotational movements of the head. Each cristae, they have supporting cells and hair cells, which extends into a gel-like mass called ampullary cupula. The dendrites of the vestibular nerve fibers, they encircle the base of the hair cells. And activating the receptors of the crista ampullaris, they respond to changes in the velocity of the rotational movements of the head, and the inertia in the ampullary cupula cause endolymph in the semicircular ducts to move in the direction opposite the body's rotation, causing the hair cells to bend. And you would see the location and the function of the crista ampullaris in the inner ear, which is shown in the higher magnification. It's embedded in the endolymph, the ampullary cupula, the hair bundle, the kinocilium here, plus the stereocilia, the hair cells, and the supporting cells and fibers of the vestibular nerve. Of the hairs in the crista, it causes the depolarization, and bending of hairs in the opposite direction causes the hyperpolarization. So thus, like before, the brain is informed, the head rotations. So the axis of the hair cells in the complementary semicircular ducts are opposite, and then therefore the depolarization occurs in one ear while hyperpolarization occurs in the other ear. And the endolymph, it will come to rest after a while. So this system detects only changes in the movement. One of the important topic would be the vestibular nystagmus, where the semicircular canal impulses are linked to reflex movement of the eyes. So nystagmus is a strange eye movement during an immediate after rotation. And it's often accompanied by vertigo. And as rotation begins, the eye starts to drift in direction opposite to rotation. Then the central nervous system compensation causes rapid jump toward the direction of the rotation. So you would see movement of the eye. So as the rotation ends, eyes continue in direction of the spin, then jerk rapidly in the opposite direction. After that, we need to look at the equilibrium pathway to the brain, the higher order functions. The equilibrium information, it goes to the reflex centers in the brainstem, and it allows fast reflexive responses to imbalance so we don't fall down. And the impulses from activated vestibular receptors, it travel to either the vestibular nuclei in the brainstem or to the cerebellum. And this would happen in three modes of input for balance and orientation: through the vestibular receptors, visual receptors, or the somatic receptors. So here, it will summarize the neural pathways of the balance and the orientation systems, which involves the vestibular receptors in the ear, visual receptors in the eye, and the somatic receptors in the skin, muscles, and the joints. And they all brings the information to the vestibular nuclei at the brainstem, and it has a crosstalk with the cerebellum. And at the end, it will control with the ocular motor control and the spinal motor control with cranial nerves and spinal tracts. Clinically, equilibrium problems are usually unpleasant and cause nausea, dizziness, and loss of balance. So nystagmus, in the absence of rotational stimuli, may be present in these clinical scenarios. The motion sickness is a common word you might have heard. Is sensory inputs are mismatched. So the visual input differs from the equilibrium input. The conflicting information causes the motion sickness. The warning signs are excess salivation, pallor, rapid deep breathing, profuse sweating. So treatment is the anti-motion drugs that depress the vestibular input, such as the meclizine and scopolamine. The next important topic is with related to the hearing and the homeostasis imbalances is that the deafness. So deafness we can divide into two major ones, the conduction deafness and the sensory neural deafness. The conduction deafness is the blocked sound conduction to fluids of the internal ear. It may be due to the causes of impacted ear wax, the perforated eardrum, otitis media, osteosclerosis of the ossicle, so on. Sensory neural deafness indicates by this word itself, it's the damage to the neural structure at any point from cochlear hair cells to the auditory cortical cells. It's typically from gradual hair cell loss. With related to the sensory neural deafness, the research is underway and to think that it's due to supporting cells and to differentiate into and the cochlear implants that convert sound energy into electrical signals are effective so far for congenital or age or noise cochlear damage. And what they do is they insert it into a drilled recess in the temporal bone, so effective that deaf children can learn to speak. The tinnitus is another clinical condition which is ringing or buzzing or clicking sound in ears in absence of auditory stimuli. This is due to the cochlear nerve degeneration, inflammation of the middle ear or internal ear, side effects of aspirin sometimes. The meanest syndrome is the labyrinth disorder that affects the cochlea and the semicircular canal. It can cause vertigo, nausea, and vomiting, and the treatment would be the anti-motion sickness drugs in mild cases or surgical removal of the labyrinth in the severe cases. Clinically, the congenital problems of the eyes and eyes are relatively uncommon, but incidence is increased by certain maternal infections. And overall clinical implication for this chapter 15. So the rubella is a German measles and is dangerous during the critical first 3 months of the pregnancy. And common problems associated with rubella infections are blindness and cataracts. And the congenital abnormalities are common with related to ear, missing pinna, closed or absent external acoustic meatus, as well as the maternal rubella can cause sensory neural deafness. So this is the end of chapter 15 overall. You may need to read more on your chapter 15 content to get much more further information. As well as I want for you to refer to the tables which is being included in chapter 15, which you would see in the PDF that I have uploaded in the D2L, but not in these presentations, but it's very important for you to look that up as well, because that will help for comparison and to know the similarities as such.